turbinates, the middle, the inferior, and the superior turbinates from the pictures on our screen. You can see from this other picture also, it's a bit clearer. Now, this is how they drain. All right, now we have the development of the sinuses. We'll talk briefly about how they develop. Now, the solid facial skeletal elements surrounding the nose are invaded by, this usually occurs in the third and fourth month of fetal life. The solid facial skeletal elements surrounding the nose are invaded by the respiratory mucosa and subsequently pneumatized. And then, like I said earlier, the ethmoid sinus are usually present at birth and reach adult size at the age of 12, when the child gets to the age of 12. Also, the maxillary sinus also present at birth. Now, for the frontal sinuses, they are rarely present at birth, usually not visible until when the child gets to age of 2. And then they are also congenitally absent, about 5% of them. In 5% of cases, they are congenitally absent. Now, the spinal sinuses are rarely present at birth also, but they're usually seen when the child gets to the age of 4. Now, what is the pathogenesis that actually causes sinuses? Now, sinuses are normally sterile, but their proximity to nasopharyngeal flora allows bacterial and viral infection and inoculation, which can also be followed by rhinitis, which is popularly usually called as catarrh. Now, diseases that obstruct drainage of these sinus contents can result in a reduced ability of the paranasal sinuses to function normally. And then they can also function normally, and when the ostia, when the paranasal sinuses are also occluded, they can also lead to nasal congestion. And then when there's nasal congestion, there is disruption of the mucociliary transport system, leading to stagnation and excretion of excretions of epithelial, and which causes epithelial damage, followed by decreased oxygen tension and subsequent bacterial growth because of the stagnation of this fluid in the passageway. Now, how does pain occur? Pain occurs when this process keeps going on, and then the pressure builds up on the sinus wall. They can cause intense pain and sinus attack. Now, the classifications of rhinosinusitis can be classified based on duration into acute rhinosinusitis, subacute rhinosinusitis, chronic rhinosinusitis, and recurrent rhinosinusitis. For the acute, from the onset to about 4 weeks, you can see it's acute. Subacute, when between 4 to 12 weeks, and then chronic greater than 12 weeks. Now, for the acute rhinosinusitis, it's an inflammatory condition involving one or more of the paranasal cavities. Like I said, it can last up to 4 weeks. It can range from common cold, which is acute viral rhinitis, to acute bacterial rhinosinusitis. We can also have the subacute rhinosinusitis lasting between 4 to 12 weeks. This subacute rhinosinusitis usually involves 1 or 2 pairs of the paranasal sinuses. We also have the chronic type. Usually the inflammation also infecting the nose and the paranasal sinuses. Because the progression of the disease, all the paranasal sinuses are now eventually involved, and this usually occurs for greater than 12 weeks. Now, for the recurrent type, there can be 4 or more recurrences of rhinosinusitis within a year, and then with resolution of symptoms, each of the episodes lasting greater than 2 months. So each episode of attack of rhinosinusitis lasts more than 2 months within a year. In most cases, each episode can usually last about 7 days, but some cases they can last for about 2 months. Now, what are the predisposing factors? Common in our environment, upper respiratory tract infections are common predisposing factors. Cold weather, like in harmattans in our environments, and then daycare attendance for children, smoking, even anatomical abnormalities, congenital abnormalities like the nasal polyps, ciliary disorders, even cystic fibrosis, septal deviations, all this can predispose, even tumors. Then immunosuppression can also predispose, like in HIV, diabetics, even direct extensions of dental infections can also predispose. So even this cleft palate, cleft lip can also predispose to um, rhinosinusitis. Facial fractures can predispose. Wagner's granulomatous, which is an inflammatory disorder affecting the small vessels of the nose, the lungs, and even the kidneys. Such patients can also have come down with rhinosinusitis. Sarcoidosis, even cystic fibrosis, like I said earlier, allergic rhinitis, asthma, polyps, all this can predispose patients to coming down with rhinosinusitis. Now, etiology classified based on etiological causes, the bacterial, viral, and the fungal. These are the commonest causes. Among them, the viral, we have the rhinovirus, which is the most common in environments, caused by influenza virus, adenoviruses. Then on the bacterial, we have all this on our screen, like the H influenza, Maricela catarrhalis, strep pneumonia, all this on the bacterial aspect. And for the even the ones that are usually implicated for chronic sinusitis are the anaerobes. Like we can see on our screen, the bacteroids, the Fusobacterium species, all these are implicated in patients who come down with chronic rhinosinusitis. Other less common causes are like the Staph aureus, influenza pneumonia, Pseudomonas, and all that. And then also for people who are immunocompromised, they can also have opportunistic infections caused by fungal infections like the aspergillosis and the mucormycosis. Now we have the allergic rhinitis. Is a hypersensitivity reaction of the nasal mucosa due to exposure to allergens. Could be acute, could be seasonal, or even chronic or perennial, that's lasting throughout the year. Now, in allergic rhinitis, there's actually an exposure to allergens, either dust particles from leaves, from sand particles. This can trigger immunoglobulin E production in the body. Subsequently, there's a binding between these allergens and the immunoglobulin E forming a complex. This complex binds to mast cells. Then the mast cells, because the combination of the mast cells releasing inflammatory mediators like the histamine, which cause vasodilatation, and then subsequently capillary permeability, where all these secretions can be cancer forming. Now, clinical features. Most common symptoms, we have the nasal congestion, person can start sneezing. That could be rhinorrhea, that's catarrh, formation, itching of the eye, and tearing. There could be headache. There could also be pressure in the head. The person starts feeling that his head is having headache and fullness of the head. Then the mucosa, the nasal mucosa, will seem that to be pale or violet in color. Then that also be transverse skin, the transverse nasal skin crease from rubbing on the nose. The patient keeps rubbing the nose and see the transverse skin. So these are from the picture here. You see there is transverse that is transverse skin, and when the patient keep rubbing on the nose. These are some examples. This is the nasal mucosa becoming pinkish or reddish, as the case may be. All right, there are two types of allergic rhinitis. We have the seasonal, like we said earlier. The seasonal could come during in the rainy seasons, like in our environment, the cold environments. And these are some of the causes are from tree pollens, grass pollens, mold spores, and this can actually last several weeks. The patient keeps complaining of catarrh formation, headache, fever, feverish feeling, and then sometimes they can disappear and reoccur the following year and at the same time, about the same time the following year. Like each season, the patient keep coming down with this condition. We also have the perennial, like this one can last in the whole year. The person keeps complaining, and some of the causes are also inhaled dust, in household dust when the person sweeps or cleans the environment. Of course, so even from animals, people who keep pets, even some food, even tobacco, people who work or who live around where people smoke, and also people who even make hair. We also have people who eat wheat, eggs, milk. All this can some people who have allergic conditions can also trigger allergic rhinitis in these patients. Now, the complications of this can be chronic sinusitis. When there's recurrence of this greater than 12 weeks, like we said earlier, the person can come down with chronic sinusitis. There will also be polyps when the nasal mucosa is swollen, edematous, and then there could be complete nasal blockage due to this. There can also be serous otitis media. Now, for diagnosis, is important to note for a diagnosis of atopy history of similar conditions in the siblings or in the patient. The physical examination, you look at the nose, checking out the nasal mucosa, there's mucus discharge, the color, also the nasal crease. Also check for social abnormalities, see there is septal deviation, see there is nasal polyps, even cleft palates, cleft lips, and anything that can predispose to this. Also sensitivity tests, skin prick tests can also be done in diagnosing this condition. Now, for a treatment, identification and avoidance of allergies, trigger factors is very much important to be emphasized. Now, during acute attacks, we can also give antihistamines, either through systemic or intranasal sprays. We can also give our local steroids. We can also give our decongestants. We can also even advise the patient to do steam inhalation, as the case may be. Mast cell stabilizers, so the sodium chromoglycates. Then desensitization, we advise the patient to always avoid trigger factors in order not to come down, in order not to have this, in order not to be coming down with this condition and then form chronic sinusitis in the future. Now, we have another form here we call the vasomotor rhinitis. Now, this is very common also in our environment. Is usually made by the diagnosis of exclusion reached after all the careful history. You must have ruled out allergic rhinitis in this patient to make sure that you come down with this diagnosis. It's a non-inflammatory and non-allergic rhinitis characterized by a combination of symptoms that include nasal obstruction and rhinorrhea. Now, like I said earlier, vasomotor rhinitis is the diagnosis of exclusion reached after taking a careful history, testing the patient with allergens to know the patient will actually come down with this disease. There are two types, the eosinophilic and non-eosinophilic type. Now, so the causes of vasomotor rhinitis, We have the temperature change, there's weather change. That people, when weather change from environment from the dry season to rainy season, some patients come down with this. Also, people who predisposed to taking alcohol, exposure to dusty and smoky environments, stress, anxiety can also predispose patients to having vasomatoinitis. Even endocrine disorders, so the hypothyroidism, even in pregnancies, when the immune system is down or is reduced, even in menopausal patients can also come down with this. And then parasymptomatic drugs can also, like usually stimulants. People who take drugs like cocaine, all those drugs can also come down with this. Then, what are the clinical features? Commonly, there is chronic intermittent nasal obstruction. What nasal mucosa is also very much important in this case. Then, for symptomatic release, you can advise for exercise. Then, parasympathetic blockers can also be given, steroids, and if condition keeps getting worse and then life-threatening, then surgery can be employed. Now we have the acute suppurative sinusitis, which is an inflammation of the paranasal, acute inflammation of the paranasal sinuses. Now, to make a diagnosis of this, there are at least can use two major symptoms, or one major or two minor. On the screen, you can see the minor and the major signs here. We have the fever, facial pain, pressure, facial fullness, nasal obstruction, nasal discharge, anosmia, or cough. So for routine acute suppurative sinusitis, you can either use two of the major or one major and two minor to make a diagnosis of this. Now, what are the etiology? Commonly, the etiological causes are either viral or bacterial. Then we have the rhinovirus, influenza virus, and parainfluenza virus. These are the most common viral agents that are implicated. Then for the bacterial, we have the Streptococcus pneumonia, Mozzarella catarrhalis, Haemophilus influenza, and also the anaerobes. Then for patients who are immunocompromised, then the fungal infections can come in. Now for the clinical features for acute suppurative sinusitis, for sudden onset, there will be pain, facial swelling, person is feeling pressure in the head. Also, there's also nasal blockage, nasal discharge, and then postnasal drip. There also hyposmia. The person starts telling you that he can't smell, he can't smell or smell sensation. Signs are more aggressive more aggressive of bacterial etiology. There could be erythematous nasal mucosa. The nasal mucosa will be erythematous or reddish. There also mucopurulent discharge, which could be yellowish or yellowish brown, as the case may be. Then also pus originating from the pneumonitis can also be noticed when there's bacterial etiology. There are also presence of nasal polyps and also a division of nasal septum in this case. Now, for acute viral rhinosinusitis can last less than 10 days. In some cases, if you see patients who come down with this condition lasting less than 10 days, sometimes it's very bacterial, because viral most times are self-limiting. Now, for diagnosis, history and physical examination cannot be overemphasized. We can also do anterior rhinoscopy to look at the turbinates, to look at the nasal mucosa, also chest X-ray CT scan. Are suspected. Now, for the management, symptoms relieve usually within 5 days. In this case, if it's viral cause, just do expected management, just put full waiting, and then things will resolve. The patient avoids triggers in the environment. The moderate symptoms that worsen or persist beyond 5 days, you can give intranasal corticosteroid sprays. Then for the severe cases, they persist more than 5 days and refractory, can also give corticosteroids, can even employ antibiotics. Education intranasal corticosteroid spray is also important. And then when condition can be resolved, can refer to specialists like pulmonologists, as the case may be. Now, we have the chronic sinusitis. We say these ones are the ones that actually last greater than 12 weeks or 12 months, as the case may be. Or sorry, rather 3 months, as the case may be. Now, for the etiology, inadequate treatment of active sinusitis, when the patient keeps going, we're not giving antibiotics or the sinusitis. Then allergic fungal rhinosinusitis, anatomic anomalies, so a division of septum can predispose this person to be having recurrent, and this person is always, the sinusitis cannot be, is not treated, and lasts longer than 12 weeks. It has underlying dental disease, can also cause this, and then cystic fibrosis in this patient, auxiliary disorders, so cystic fibrosis can also lead to chronic sinusitis. Even chronic inflammatory disease, such as the Wagner's, like I mentioned earlier, can also predispose this patient. Now, organisms that usually implicated are the bacteria. We all know viral are usually self-limiting, don't usually last longer, like the bacteria or the fungi. Now, for the bacteria, we still have our pneumonias here, the influenzas, the staph aureus, anaerobes. And then for the fungal, so this can actually last longer. Obstruction, you see them always complaining of nasal obstruction, that keep coming to the hospital for the same complaints. There's purulent discharge, like headache, pain, over the sinuses, there's halitosis, person feels breathing, telling you that he's breathing bad, taking bad breath, yellowish brownish post-nasal discharge, chronic cough, person keeps coughing, even maxillary dental pain. Person can also have these symptoms. Now, for treatment, antibiotics are very much important in this case. Treatment usually for 3 to 6 weeks for infectious etiology. We can use our penicillins, the clarithromycins, we can use our fluoroquinolones, and the clindamycins, even flagyl can also be employed in this case. And topical steroids are also very much important to reduce inflammations. Saline spray is also very important. And then conditions keep getting worse. We can employ the surgical and procedure to the surgical team. So manage all disease tissues and bone. That's also, they're all infected. Then post-op drainage also involve application of the pre-existing sinus cavity. Now, also in the surgical procedure, we can open. Depends on the site. Now for the open, there's antral puncture, intranasal astrostomy. Also intranasal or external ethmoidectomy. There can also be trifiniation of the frontal sinus, osteoplastic flap operations, then external frontoethmoidectomy can also be done. Sometimes if the sinuses are blocked, then they have to just operate to decongest. They can also do endoscopic, functional endoscopic sinus surgery can also be done in this patient. Now, complications can arise from benign to fatal, as the case may be. Depending on the treatment protocol employed. Then the incidence of complications from both acute and chronic sinusitis. Antibiotic treatment protocols and effective antibiotics used. Complications can be divided usually the veins. Also, the frontal sinuses, like we all know where the frontal sinuses are located, is rich in these veins, especially during adolescence. So, like I said, some people have the Wagner's and dermatomatosis who have actually that disease can come down with these intracranial complications because of the fluid. Now, for also intracranial complications, we have the can result in meningitis, usually there's involving the sphenoid or the ethmoidal sinusitis. Person can come down with meningitis. Then for people who have issues with the frontal sinusitis can come down with epidural abscess. These are all intracranial complications. Subdural abscess, most common in patients who have problems or complications arising from the frontal sinuses. Intracerebral abscess, also from the frontal, the superior sagittal sinus thrombosis can also arise from the frontal due to the proximity of the frontal sinuses to the intracranial cavity. Also, the cavernous sinus, like also the cavernous sinus thrombosis arising from complications from sphenoid and ethmoidal sinusitis. In rare cases, there can also be proptosis, especially if the part of the brain that controls the optic, that's wherever the optic nerve is affected, there can be proptosis. There could be chemosis, ophthalmoplegia can also occur. If all this can actually arise if the cranial nerve, the cranial nerves that control the optic nerve, the cranial nerve 3 are affected. Now, these are some of the X-ray features, though they can't be appreciated here, but these are some of the X-ray features of the complications you can actually see on the intracranial. All right. Thank you very much, everyone, for listening. Hello.
Yes, we're here. We're here. How about you?
Beautiful presentation. We're here.
Yeah. Thank you
Yeah.
for the
Nice
wonderful presentation.
Nice presentation. I was just flowing. I was just flowing.
Thank you very much.
Yeah. Thank you, Dr. Pascal. Where are your
Dr.
references?
Pascal, thank you. Really nice.
Where are your references, Dr. Pascal?
I cannot put them out because I'm using my phone. The team cannot actually cannot finish the typing before the presentation started.
Pasquilo. But just going like at each slide, I was sorry happen. I now forgot to ask questions. And I forgot to ask.
Yeah, see, anyway, you just posted now.
Questions.
There are no references. Beautiful presentation, but no references, Dr. Pascal. Okay. So let's
Dr. Taiwo, okay. Dr. Taiwo said good ENT examination is important. You find in some cases, especially children, you could find a foreign body which was inserted at some point. Cotton bud, yeah, that's true.
Yes, very true.
That's true.
I think one of the
Pascal.
Okay, Dr. Taiwo is
one of the things we notice is that I've seen one or two cases like that. They the child keeps on coming back. They go from one doctor to the other. They give antibiotics. The child was referred to Professor Ibiekwe, who took out his diagnostic set and just pinched the nose and then exposed and looked in there with his headlight and pulled out a small old cotton bud that was
Oh my God.
that was just there. It has changed color. It was suppurative and all that. So, I learned a valuable lesson that day that, at times when they come initially, they are coughing, they have nasal discharge, it's yellowish in color and all that. We just say, this, and let's take a swab. Just put your swab in there without actually taking time to get a diagnostic set to even look and see, can I see anything there? So, it's something that we need to think about.
Yeah. Thank you very much, Dr. T.
Thank you, Chief.
There was another question Dr. Darling asked. How can you differentiate between allergic rhinitis and asthma? Dr. Pascal, how do you differentiate allergic rhinitis and asthma?
Okay. Okay. From my understanding, allergic rhinitis from asthma. For the classical features of asthma, they usually have wheezing, cough, which is more at night, chest pain. And apart from in the asthma, there is no pathological, and there is no infective agents, viral, bacterial, or fungal. And then for the allergic rhinitis, most times there's also exposure to all these pollens, but there is no the cough, or rather the wheezing is not actually there compared to the asthmatic patients. And then there is cough, but the patients and that's not much, I know. And then also in asthmatic patients, they usually have catarrh, unlike the allergic rhinitis. So
difficulty in breathing.
Difficulty in breathing also. Yes, it's more in an asthmatic patient than
that's a major difference.
Allergic rhinitis, they usually don't have difficulty in breathing.
Yeah, that's the major difference. That's what I was waiting for you to mention. Okay, all right. Okay, thank you. I don't know if Chief has any other thing to say concerning that, as regards that question.
Hello.
Yes, sir.
Hello.
Evening, sir.
Hello.
Yes, sir. Well, with you, sir.
Dr. Duffy, I want to talk.
Thank you very much. I think I'm also learning so much from this presentation. Just like the presentation was quite rich. Let me start just like I've been noted. The slides were not properly organized. There was no numbering. There was no title. No, you just start. The first thing I saw was your name, the name of the presenter, not the title. The slides that we are going to do should have a title, Rhinos. And also, let me quickly say that it looked as if there was a little problem with this presentation. We want, it would be nice for the senior registrar to be sure that everybody presenting knows how to use the apps. I personally, I don't know, I'm also learning, so that the hitches we have can be avoided.
Yes, sir.
And there's no excuse that, oh, I'm using my phone, that's why I can't get references. It's not accepted. Let's take it as, so far, I think you have been doing very well. So, let it be data and time can be very meaningful because we are to learn. And also, rhinosinusitis, is it part, can we call it upper respiratory infection? And if it is, you should always know that is a part and parcel of the URI. And one thing that really I didn't hear at all, we know the time that we are now. Are you hearing me?
Yes, sir. We can hear you, sir.
Okay, the time we are now is the COVID. So you cannot discuss this without mentioning anything about coronavirus. You cannot. And you should make this very rich, because it's not just the textbook. You know, we are practitioners. The situation that we are now makes it mandatory that every doctor should be conscious of that, the coronavirus effect. And also just like you have noted, any upper respiratory infection, rhinosinusitis, because you may not be able to, as you try to differentiate whether it's allergic or everything, also find a history of allergy in the family or any other areas like atopic dermatitis. Also, the investigation that you mentioned was testing for sensitivity. Is that done in an environment? It's always good things that are not done in an environment stated that yes, this can be done, but it's not done in them. In fact, even outside the way it is done, it is not because most of them are. There's a lot of you can hardly identify what the problem is. So as you mentioned investigation, please make a comment so that we don't just that makes it more interesting.
Yes,
I hope you are hearing me.
Yes, we can hear you, sir.
And also be asked to examine a patient that have rhinosinusitis. You should be able to know what examination to do. And one of the things I did not hear is, how do you examine a patient with sinusitis? I know that I'm sure that you can, you can percussion of various sinuses. And when you percuss, if you feel pain as you percuss, that's what you try to elicit as a patient. So it's very, very important that you should not omit that. Not just pains that you as a patient, you must also demonstrate that pain by percussion. Also, treatment of in our environment, most times they said, oh, don't use antibiotics, especially in acute rhinosinusitis, acute what you call societies don't use antibiotics. Not in our environment. In our environment, please, all patients presenting must have antibiotics. You can always defend that because of our environment. And living in an environment, you can't predict where the patient is returning to. So don't always, it must have that. And also something to decongest this thing. Then another aspect of this thing, which I've also I think we should also have something in mind is the referral. Please, let's know that we are family physicians and we are the first doctors of contact. Never, never, never make any presentation without referral. Yes, you mention it. For example, you talk about surgery, these big investigations. Is it done by you? Even when you mention them, tell them you refer this patient, and those specialists, this is what they will do. don't say it as if that's what you do, because at times we keep patient too long. And once you give that impression, it doesn't make you a family physician. So as you mentioned, some of those of tests or some of those treatments, please specify that the referral, I keep on saying referral. Referral is an active form of our management as family physicians. So never forget that. Well, somebody was asking the difference between asthma and rhinosinusitis or allergic something. You should, I think you are quite right that you must answer as if you must be very practical. The other one is an upper respiratory tract problem. The other one is lower. So if you want to get a physical examination, for example, listening to the chest, the asthma would be expiratory bronchi, while the other one would be inspiratory, not necessarily bronchi, transmitted sound. Because if it's a child, that is more of breathing from the nose. That's what you find. So I think that you should add that to whatever I've been saying. And also steaming. I don't know what happens. I think, coronavirus that makes steaming to become because every day you hear people steam. Steaming had been an old important treatment for every upper respiratory infection. Even, the rhinosinusitis. So never, it's a simple thing that you do. And the essence of steaming, you know how it works, allowing the mucosa to calm down, allowing the cells to be able to discharge whatever it has, so that at the end, you can decongest. So steaming is an important thing. I believe that we should also have had it. I think on the whole, I think the presentation was very rich. I learned so much about it. But please never do anything on the face without thinking about the COVID. Thank you.
Thank you very much, sir.
Yeah.
Really appreciate
Thank you very much. Thank you very much.
Thank you very much, sir. Really appreciate your contribution in this presentation. We've learned so much ourselves. And,
thank you so much. Nana, you did great.
So, HOD was trying to pose that she's having some network issues. She's not been able to hear most of our questions and answers. So, sorry about that, ma. So, I don't know if we have any other question concerning as regards this presentation before we end the meeting.
I will only say that we're so few attending the meeting.
Yes,
but,
very proud. I'm going to comment on that on the group.
Just like Dr. Udofia, Chief Udofia said, I learned a lot, and I don't know about them. See my book in front of me. As he was just talking, me, I'm just knowing what I'm doing about my book. I have a NASA foreign body case, but it's okay. Anything they want to do, if they don't want to participate, we'll leave them.
Well, we will not completely leave them because we've discussed this with HOD. Yes, we've been talking that this presentation is for us and it's for us to benefit. If Chief can come, our chiefs can come and attend this meeting out of their busy schedules. We as residents don't have excuses. So if our
Dr. Matthew is here.
Yes.
Chief Darling is here.
Exactly. There are more senior people here than the junior doctors that actually need these presentations even more. So it's poor and not encouraging at all. Like I discussed with HOD today, or yesterday, that attendance is very important. It's mandatory, and if you're found wanting in terms of attendance in presentations, sanctions will follow. So let's all take note. I'm going to post it on the group now. Attendance is very poor. Can you just 3 residents here? You know, two residents.
I'm not even sure
Chudi
they are
and
really
Abinde.
here.
They may not even be
sure
here.
really
They just started their Zoom and
we
just
are
logged
here, you can sign in.
sign in and logged out, and they are doing other things. Anyway, sanctions will follow very soon.
Yeah.
We've been taking attendance, and we know those that have been consistent. Yes. We know those that have been consistent and those that have not been doing well in terms of attendance on meetings. And the extra calls will follow and other sanctions will follow. So I want to encourage everyone to do the little that is expected of us to attend these meetings, even if you're not the one presenting. So please, let's improve on this. This is poor attendance. We used to be up to 20 and above. Now we just have 9, 10. Very poor. Very poor.
But I wonder what happened. We used to be 20 and
yes.
What happened?
Yes.
If I might say something,
yes,
I think you find out that these presentations, these are the things you will see in Ibadan or Abuja when you go for exams. For example, look at what Chief Ridofia said just tonight. Examining those nice sinuses and doing and percussing. I forgotten that completely. And then you enter a station and you see a patient there. They give a history. There's a history of sinusitis. Show us one single examination you will do for this patient. You now start carrying diagnostics instead of just percussing those different areas of sinuses and eliciting pain.
Taiwo, you are even talking
it's
about
mandatory
part 1. See what I'm reading, as in, it's not even just in part 1, it's in part 2. As in, it's, I don't know. What's that thing that is making them not come to meeting? I think it's a giveaway. I think it's a blessing, for us to be here. What is that thing that's making the residents not participate?
Hello, Chief. This, this week we've been on a revision course. So we had a long day. Yes.
But it's not only today now. It's not only today.
Since Monday, we've been on that, and it's on Zoom. So practically, it normally ends at 5:30, 6 p.m. and it has not been easy with work. So for this week, I don't know.
Okay, let's watch you guys after this week then.
Just an hour. It's just an hour of presentation. Well, that's your excuse, but it's not good enough.
See my problem, eh?
It's not good enough.
It's really enlightening.
Yes, it is.
Can I say something?
Oh, Chief maybe wants
Hi.
Yes, ma'am.
Hi, good evening. Good evening, sir. Good evening, Dr. Pascal and every other person. Based on what the person said as regards having revision, it all boils down to communication. If you don't communicate to your chief reg, how exactly do you want him or her to know what's holding you down? And so this is the same problem we've been having over and over and over again. If you are unable to attend, lay your complaints to the chief reg. He's the go-between person, you understand? And that's how it is. Communication is key. That's my own contribution.
Thank you very much, ma'am.
Okay, thank you, ma'am.
Thank you very much. Communication that she just said is key. You had some issues, you were attending update courses and this and that. You send a message, just a message, okay, see. Well, like update calls, or we're just rounding up, or I'm out of data, or one thing, like Thomas always, you see Thomas every time she's having challenges even with network. He posts on the group that, look,
Thomas posts it on the general group.
I'm on call, he will post it. Exactly.
Anyway.
So I think we should all learn from him. That's the right way to go about things, and not just ignoring meetings and not even sending any message or communicating with anybody.
Apart from that, even if they are stressed, I'm telling you, these meetings will add to your knowledge.
I don't know how you want to say it. It's a very big positive. As in,
I like how Dr. Pascal is always saying, I learned so much. It will add to your knowledge.
At that stage, if Dr. Dofia could pick up things and learn here, you can imagine the junior doctors, what we can learn from all this. So we should not take it for granted.
Just 1 hour, just sign in. I mean, you can even be doing your cooking and listening to the person presenting. That's the beauty about Zoom. You say, oh my God, what did this guy just say? I don't know. You know, you can, there's so many things. You can be doing so many things and listening to the Zoom meeting. Then you hear something that strikes your head. Then you quickly send a chat. What did you just say? You know, I don't know. But anyway, that's just me talking. But they need to show more dedication to their residency program.
Yes. Yes. Definitely.
The HOD cannot sign in every minute, every meeting, and the residents are not here. It's unacceptable.
Yes. If we can have our senior colleagues here and the junior ones, we don't have any excuse not to be here. So as it is now, from now on, we'll take attendance of meetings very seriously. I'm going to post it on the group. Take attendance, and monetary fines will be placed on failure to attend meetings. You know, apart from maybe extra calls or any other thing, monetary fines. You know, so any meeting you miss about 1,000 or 2,000 or something, you will pay something for missing a meeting if there's no proper explanation for missing that meeting. So I'm going to post, I'll discuss with our HOD and we'll place that fine and it's going to stand and we'll follow it up. And if you default in payment, other sanctions will follow. So let's all take note. I'm going to post it on the group. And please, I want to encourage everyone to improve. And then I pass the message, those that are here, please pass the message to the rest. We'll take this attendance very seriously. And every meeting, I've been taking attendance. I have the whole attendance list. So we know those that have not been doing well with attendance in meetings. So from now on, if it continues like this and if there's no improvement, proper punishments will follow and we'll find those that are found wanting. So thanks everyone for today's presentation.
As regards to monetary implication, Chief, please.
This Igbo man don't hear money now.
Very important. Very, very important, Chief. We are already in the financial testing already. We want to add another one, Chief. Please. That one is.
So people, tell your people, all of you should improve attendance. Pass the message. Because if attendance does not improve from the next meeting, honestly,
it will improve, sir.
And I'm not just saying this.
I'll tell them about this monetary issue. I'll tell them about
let me tell you something.
They talked for the first.
Yes. Because of money. He has had money now. So let me tell you something. I actually discussed this with the MD, the medical director. He's interested with all these academic activities, even if it's not always here. He's very much interested. And if he sees it going this way, he will not be happy because he's the one that made us begin presentations like this and he wanted to continue at this, pace and all that. But the way it's been going recently, it's not encouraging. And he knows about it. He's the one that first suggested these fines. So I've been trying to play it down, but as it is now, it will have to start. He actually mentioned it before. So we all need to improve. We all need to improve.
It's not even so much as punishment. They're having a challenge. They are doing residency in COVID period. So anything that you can grasp on, because your program is going on. You are in a program. I swear you're going to go for exams and it is these little things that are going to count. They are not having it easy. So they should be scared. Like, now, wow, this is our own. My daughter drew me. See what my daughter is drawing. Because that I'm raking. My friend. So you guys should be scared. As in, be challenged and like try to grasp at any opportunity that you have to learn or anything. Anyway, like.
Okay, now
Thank you, Chief
we
Lulu.
improve,
I'm also thinking that.
I promise.
I'm also thinking that you know these presentations, you will hear something that you will not hear again until you enter exam.
Exactly.
Never.
Exactly.
You will not even read it. You will not read it. You will not even read it. You know, they are thinking that they will read. When they read rhinosinusitis, you see, like, you will never read it.
Yeah.
Coming from us, you will never read it. Don't deceive yourself. No matter how good you are.
Exactly.
Anyway, we have to end the meeting. It's past 9.
Yeah. Thank you, everyone. So I'll be...
All right, Chief Itama.
Thank you, Chief Lulu. Thank you, Chief Mimi. Every other person, thank you for attending today's meeting. So
Good
let's
night,
all have
everybody.
a good night.
Mimi.
Good night, everyone.
Dr. Dafia.
All right.
Chief
Bye.